This is the Head Rush Podcast with Paul Fraze and Corey Berry.
Welcome to the Head Rush Podcast. I'm Paul Fraze, and I played 11 years in the NFL, and our co-host, Corey Berry. He rode professional rodeo for 9 years. Corey, do you want to take a nod to the audience, or?
How y'all doing?
At the Head Rush Podcast, we talk about everything related to brain trauma and brain health and wellness. We talk about traumatic brain injury, TBI. We talk about CTE, which is chronic traumatic encephalopathy. TES, Traumatic Encephalopathy Syndrome. It's actually the closest you can be diagnosed to CTE while you are living. We talk about repeated head impacts, repeated blast exposure, and we cover how traumatic brain injuries can and will cause mental health issues such as depression, addiction, lack of executive function, memory loss, even suicide ideation, as well as degenerative neurological issues. These symptoms can be found on the Mayo Clinic and Boston University websites under symptoms of CTE. Our mantra is how to cope and find hope. We focus our energy on finding therapies and sharing hope through education and by raising awareness.
Great job, Paul.
Thank you.
Hey, today I got a great honor, Paul. We've had our Dr. Gordon and Dr. DeMayo on. We've had this. I got my local neurologist that I see, I believe, every 3 months. And it's an honor for me to introduce our next guest. He's not just a doctor, but he kind of handles all the mush in my brain, and
That's a lot of work.
it is for him, I'm sure. And it's Dr. Victor Kaytser. Is a faculty associate in the Department of Neurology at UT Southwestern Medical Center in Fort Worth. He specializes in general neurology, headache medicine, concussion, and sports neurology. Dr. Kaytser earned his medical degree at Ross University, completed his residency at Rutgers University, and a fellowship in headache medicine, concussion, and sports neurology at UT Southwestern. Certified by the American Board of Psychiatry. I didn't know that. And neurology. He joined the UT Southwestern faculty in 2022. Dr. Kaytser is a member of the American Headache Society and the American Academy of Neurology. He regularly delivers presentations and invited lectures and has written peer-reviewed articles related on these areas of his expertise. Welcome, Dr. Kaytser. Thank you for showing up.
Thank you. Thank you for having me on the show.
It's our pleasure to have you, and we're thrilled. First of all, you're talking to a football player and a rodeo guy, so you might have to bring it down a couple notches. But,
of course.
Your bio, somebody like you, your bio, we could probably read your bio for about 23 minutes if we read everything you've accomplished. But what obviously when you get into medical studies, you don't choose, your first year of college, right? Or how did you come upon neurology and headache specialist and concussion and sports neurology?
Yeah, it's kind of a long, ever-evolving process. When you start medical school, every specialty in medicine is thrown at you, and you're kind of trying to see where you fit in the most. I knew I liked neurology. I did pretty well in it in medical school, and when it came time to choose residency, that's kind of where I felt the most at home. And it wasn't actually until later on in my residency, when you had to figure out, okay, now what do you want to do with the rest of your life, that headache and traumatic brain injury started coming in. And I remember seeing a pamphlet for a lecture on traumatic brain injury with Dr. McKee at Princeton. And so I ended up attending it because I was doing my residency in New Jersey, so it was right there. And that's where it started to come together. Oh, I can combine my passion for sports and neurology and just do this for a living. And then it just started to evolve from there. I think what what further kind of pulled me into the field is the fact that concussions, traumatic brain injury is still this invisible disease that we have to try to navigate around. For most people, you see a normal MRI of their brain behind a very composed face, yet people are describing frequent headaches, light sensitivity, nausea, mood changes, cognitive changes. And a lot of people, I think, get just kind of like brushed off. Okay, just walk it off. You're probably just anxious or depressed. And I think it compelled me more to delve further and see if I can actually make a difference in people's lives.
That's so a lot of, okay. One of the first questions that you ask a patient, do you talk about, have you experienced any head trauma? Is that in your take-in questions?
Usually when I'm seeing any kind of headache patient, trauma is one of the first things we think about. And so I'll usually ask them any prior history of trauma.
Mm-hmm.
Now, someone like me and you, we didn't look at repeated head impacts as trauma.
Yeah.
So, like when you asked me, it wasn't so much as trauma, it was more on the repeated head impact side. But I also did enough research to find you that I wanted a neurology that knew about this stuff, because we were already, Boston University has already scheduled me for Dr. Tanner. And by watching Concussed and being first diagnosed in 99 with cognitive nerve damage, I already had enough in me education-wise to try to figure my walk. Meeting you, it moved my walk a lot more ahead with Tanner and yourself, because you both have paid close attention to concussions, repeated head impacts, repeated blast exposure.
And maybe we also need to think about asking better questions, or the right questions, because I come across a lot of patients too, and I'll ask them, how many concussions have you had in your years of NFL? And they'll be like, well, only 1 or 2, but I've had my bell rung, or I've been dazed, pretty much, multiple thousands of times a year. And so those more detailed questions, we have to try to draw out of the patient a little bit better.
That actually, you just covered that. We wanted to ask, what is classified as that subconcussive hit or getting your bell rung, and how is that different from a concussion?
Yeah, and that sometimes I think can be a challenging question to answer, and that's where future research into biomarkers is going to help guide our clinical judgment. So there's a lot of times where players will get hit in the head and may feel just a little dazed, off balance, ringing in the ears, the metal taste in their mouth, and that may never evolve further into more persistent symptoms like migraine headaches, memory loss, attention deficits, behavioral changes. I usually think more concussion when you have more of those lasting symptoms, though the culture perspective has to change, I think, because those minor, what we call minor head impacts, I think are really the driving force, it sounds like, towards TES and CTE. Those repetitive head impacts that go unnoticed, and the second impact syndrome of putting players right back into the game because you don't think they had a concussion, but we really don't know what's happening on a biomolecular level at that time. All we see is, are you oriented to the date? Can you walk a straight line? Okay, go back into the game. And I think hopefully one day with biomarkers that becomes a little bit more definitive when to pull someone out and when not to.
Well, and they say it's gotten a lot easier and for the players a lot more safer, because now they go into the blue tent, they do the because you talk about when you got knocked out, you went off the field and immediately there was an interception, or I can't remember the whole story, and you came right back on to play later.
And I left on the third down instead of the fourth down. And I said, where the heck am I? What am I doing out
Do you
here?
remember where you were?
I do now. I woke up, well, it was in the first quarter, and I finally came it was like a focus. I was looking up at the lights. It was a Sunday night or a Monday night, and I was looking up at the lights, and everything just focused with about 5 minutes left in the game. And I said, oh, we're at the Pittsburgh Steelers, and we're playing on a Monday night or whatever it was. So it was kind of wild. But at that point, after this, and I want to come back to the second impact, because I didn't know how dangerous that could be. But I got hit. I put my head in the ball, and I got knocked out for 8-9 seconds. We got the ball. I followed my my teammates off the field, and then our quarterback threw an interception the next play, and I just followed my teammates back on the field, and I played 3 downs, and I should have stayed in for a punt, but I didn't.
So what is the big? Because we've talked about it, how I've been knocked out on a horse, and then fallen and hit my head on the ground because I was unconscious on top.
Mm-hmm.
There's only one way off at that point.
Okay.
What is the degree, or the word I'm looking for? What is that second hit? How much more damaging is it?
And I think that's also something that's not entirely clear, but we have seen more catastrophic injuries from a immediate second impact. And we know from other studies, like for instance, MR spectroscopy scans, where they would look at N-acetyl aspartate levels in the brain, which is basically a metabolite in the brain, in the tissue. And they would see it come up and come down after an acute concussion. But those who were found to have a second impact, it took them longer for those levels to recover back to normal. Now, I think one of the reasons we don't use it yet in clinical practice is because it didn't necessarily correlate with clinical symptoms. So we're not sure what to make of that. But I tend to believe that, and we're starting to learn now that it's not necessarily the individual concussion that increases our risk of TES or CTE, but the years of repetitive head trauma, which is why the diagnostic criteria includes like that minimum of 5 years exposure. And I think a lot of that has to probably do with that second impact syndrome, and how much is that really affecting the brain. And I think once we start to develop better biomarkers, we'll be able to see it's just too early for you to go back into the game. You have to wait 10 days, 14 days, before going back.
And before we get into talking about, and I want you to explain TES and the steps, and when we do that, Emilio, if you could put up the board so the people can see it. When I came and saw you, I was already sent by Boston University to go see Tanner. And I'm becoming a very big advocate on TES becoming a billable code. Making it because right now it's a clinical diagnosis, it's not a medical diagnosis, correct?
Well, even worse, it's as a community, we still feel like it should be a research term versus a clinical diagnosis. And so I kind of, since I'm in the field, I kind of tiptoe that line. I'll talk to my patients about TES and CTE, what the criteria are, but I don't necessarily want to hang my hat on this is for sure TES or for sure CTE, because we just don't have enough definitive data just yet.
So you felt better for me to go see Dr. Tanner to get that. Why is that? I mean, why is neurology having such a hard time? And I think we see it all the time on our support groups. We see it through talking to people. Neurologists, they're not paying attention to repeated head impacts or repeated blast exposure or second concussion syndrome or all of that. And it's still kind of, why do you think neurologists are so nervous to go, and you were nervous with me to go down that road? Why is that, do you think? Is it just education and knowledge? Or I don't think Tanner's, and I don't know, I mean, Tanner's one of the top out, but what is that separation? Why were you nervous to go down that road?
Yeah, part of it could be experience, knowledge, and I just want to make sure we're doing the right thing. And one of the big issues is that with TES, that includes cognitive deficits, behavioral deficits, and a lot of times these alone can be a problem for anyone. So just having depression can be debilitating, and people with depression often have cognitive issues as well, and sleep issues. Same thing with migraines. If you have frequent migraines, and I usually tell this to a lot of my patients, that if you have frequent migraines, you're going to have trouble sleeping, and then the less sleep you have, the more depressed you'll feel, and then the more depressed you are, the more cognitive. So it's this vicious cycle that people fall into. And a lot of these similar symptoms can happen with TES. So my goal generally is to bring awareness of it to the patients, but also see, how effectively can we address the migraine, the behavioral, the cognitive, and see what improves, what doesn't, because we don't yet have an established treatment or diagnosis for TES. So in your case, I was Dr. Tanner's great memory disorder specialist, and so he could give perhaps better insight into making sure we're not missing something else that could be more easily treatable.
But I mean, with someone like my or Paul's experience come and see you, and I'm pushing on Paul to go get this clinical diagnosis because I think it's needed. But I started rodeoing at a very young age, professional 9 years, all the way up to the age 29. And I know the PET scan that you sent me for helped with the diagnosis, the MRIs, everything like that. Blood works that you and Tanner have done. The genetics with the male probably helped you. The hormones with Gordon probably helped you. And that's what I appreciate about you so much is a lot of the doctors, if you go outside the normal Chris Nowinski medical and seek outside help.
Complementary medicine through nutraceuticals or this and that, or
Right.
TMS or so on and so forth.
That you're more up to accept that and look at everything to help me out. But with someone with experience, like if Paul walked into your office, 11-year pro football player, I almost said the 3 digits, pro football player walked in and had the symptoms I have, would you feel more comfortable diagnosing the TES clinically, or would you still want him to go to Tanner?
Well, I think I may be getting more comfortable, but I still think I'm hesitant with the TES diagnosis. Like I said, I'll talk about it, discuss it with the patient, say that this is on the table, but we can't prove it. But I think one issue, as well as, from the other researchers and conferences I've gone to, they've analyzed people who've had, let's say, like 20, 30 years of boxing, and they'll analyze their brain and it'll be perfectly normal, or they'll have evidence of CTE, but they had no symptoms prior to their death. And then so we're running into trouble, why is this person with 30 years of boxing experience not having tau deposition, and this person with no experience in boxing also has tau deposition? This one has all these symptoms, this one has no symptoms. And I think there's just been a lot of conflicting data to really say, to be confident. Yeah.
Ladies and gentlemen, this episode is brought to you by Millennium Health Centers, Dr. Mark Gordon at TBIHealthNow.org. He signed on with us. You've seen him in our episode 2 with Dr. Mizell DeMeo and Dr. Gordon.
Dr. Gordon's been featured on a movie, Quiet Explosions, a documentary about TBI, featured Andrew Marr, a Green Beret blast explosive specialist. And they talk about TBI, PTSD, traumatic brain injury. And gosh, I've watched that movie about 4 times. And I know Dr. Gordon has also been on Joe Rogan 6 times. So he has something good and powerful to say about about TBI, traumatic brain injury. So go to tbihelpnow.org.
Correct.
And make sure you get in touch with their team. Dr. Gordon also works with the military. Do you want to?
Yeah, he works with the United States military. He's done the Pentagon. He's working real close with them. If you're a veteran and you need help, go to tbihelpnow.org. Dr. Mark Gordon quit his private practice just to work with the military.
Work with veterans suffering with PTSD.
Right, PTSD, TBIs, and repeated blast impacts.
Exactly.
And if you are a veteran, there's nothing closer to my heart than the people that serve our country and protect our way of right and our way to be able to do this podcast for you. So go to tbihelpnow.org and get the help you need. Mark Gordon, we work with him on the Brainwell program through Mizell DeMeo. If you go to tbihelpnow.org, there's a list. There may be a provider in your area in Canada. He's all over. So go to tbihelpnow.org and check it out.
I think it's pretty amazing. Our Dr. DeMeo, she's a doctor of psychology, psychiatry.
Psychiatry.
Thank you.
Same as Kaytser, I just found out.
Exactly. Your doctor.
He's also my shrink, and I didn't know.
But she does some genetics. She does the MTHFR. She does the CompT. She does the BDNF, and that's what I was interested because the BDNF, the neuroplasticity, right? And some of us, me included, are low in that factor. So I don't respond to a concussion very well. The way that somebody, and this is just one factor, because you're talking about there are so many factors to have a diagnosis or clinical diagnosis. But the BDNF, in my novice thinking, is if you have a low factor, you're not going to react to concussions and brain. You're not going to recover as fast with somebody that has high neuroplasticity, or that factor is the BDNF is high. So the 30 years of boxing, is it because he had an astronomical BDNF factor? I don't know. I mean,
yeah, and that could be the case. It's something I could look into further. There's other biomarkers that are being looked into as well, like the GFAP, the glial fibrillary acidic protein. There's the NFL protein, which is the neurofibrillary tangles. Neurofilament light chains.
Oh.
And these are all kind of proteins that are in the neurons. So when there's damage, they get released, and we can kind of track them over a period of time.
You're talking about 10 minutes ago, you were talking about meeting Ann McKee in 2019. And I was involved with clinical trials to find biomarkers. You've mentioned biomarkers many times already. Through biomarkers for CTE back at Boston University probably 10 years ago. And now they have, CLF has the blood draw. They know Alzheimer's. I guess Alzheimer's.
BankCTE.org.
Bank CTE.
I'm a member of that, and so are you.
BankCTE.org, where they're trying to go biomarkers for CTE just for a blood draw. And I believe, you might want to shed some light on that, they got the idea, or the technology has advanced for Alzheimer's, where they have some verifiable biomarkers from blood draws. Is that correct, or am I?
Yeah. So in Alzheimer's disease, we also see some elevations in tau, but it's specifically the p-tau 217 seems to be very specific, and now you can actually test for that in the blood versus doing a PET scan or a lumbar puncture.
Is that phosphorylated tau?
Yeah,
Or-
sorry, the
okay.
phosphorylated
No, that's
tau. And then so with that, some overlap into the CTE and seeing if some of those can be useful, or a combination of biomarkers needs to be used to make the diagnosis. And along with Alzheimer's, we do know that traumatic brain injury can increase risk of Alzheimer's. And so sometimes I'll do some of those testing to test for Alzheimer's, because we also now have some newer treatments for Alzheimer's as well.
Right, and you were testing me to see for the fusion.
Yeah, there's an infusion therapy that's given once a month because if there is buildup of amyloid plaques in the brain, this infusion therapy can help to remove those plaques and slow down or hasten that progression as much as possible.
So the that's the holy grail, or that's another component of a treatment for Alzheimer's, and which is a tauology disease, just like CTE. But CTE, you're more worried about the. Do you have NFTs, the neurofibrillary tangles, in Alzheimer's as well, or is it more a CTE indication?
You can have them in both. The Alzheimer's seems to be more of the amyloid plaques, but you do see neurofibrillary tangles. You can see that in CTE. The location of those plaques also seems to be a little bit different, which is something Dr. McKee is trying to shed more light on as well.
I'm totally jealous.
Why? You haven't met Dr. McKee.
You both have met McKee. He's doctor.
I found out, which was very interesting, because I found out she was going to be in Tampa at the Bruce Mac Parkman Foundation CTE Awareness Conference last year in Tampa. In July, I think, June or July. And I saw Ann McKee's going to be there. So I live in St. Augustine, and I drove that 3.5 hours, and I met my hero. But it was, she's been at the forefront, or probably one of the tops in, she's probably held a lot more brains than a lot of people doing the autopsies.
I'd like to meet her before she puts my brain in her hands.
She's also gone through all the controversy, all the chaos, and made it on to the other side. And now she's actually getting the recognition she deserves for all her work.
It was ugly there for a long time.
Yeah. Especially you're dealing with big businesses and trying to change the culture.
The 3 alphabet.
Yeah.
Yeah. Well, it is. Yeah. You were mentioning too that the repeated head impacts, and we're just being introduced to repeated head impacts and repeated blast exposures, and you do hear from CLF up at Boston University that CTE is directly related to repetitive head impacts. And how many? No telling.
Yeah,
But the TES diagnosis, clinical diagnosis, they have some criteria. They have like 4 or 5 criteria for that, right? Talking about exposure to. Can you share with us some of the TES?
Yeah, if you want to pull that up, Emilio, and in Kaytser, I know you got it in front of you. That's probably a little bit better. Can you describe it a little bit for us?
Well, yeah. So they have several categories they'll look into. The first one is the identifying substantial exposure to repetitive head impact. So they specifically include sports like football, but other high collision sports like hockey, soccer, rugby, wrestling, and they recommend at least a minimum of 5 years of organized sport, 2 of which have to be at least at the high school level. And then they specifically have a different section for military service. So this includes multiple blasts or other explosions, non-combat exposure to explosions, multiple blows to the head for an extended period of time. And then goes on to the symptoms. So one is cognitive impairment, and they want you to have all 4 of these. So representing...
If you'll go to the next. Okay, go ahead.
So they want to see a significant decline from the baseline functioning, progressive nature. The deficit specifically should be with episodic memory, executive function, but you could have additional areas of cognition that are also affected. And then impaired performance on maybe more formal neuropsychological testing. The neurobehavioral aspect, we tend to find more anxiety, depression, impulsivity, suicidality, addiction, and some of those features can also be involved in there. And then it's also understood that people can also have a delayed onset of symptoms, even years or decades after they finish playing. And so that delayed onset could be a telltale sign as well. And then the lastly is specifically looking at the maybe some of the pathology. So basically the cognitive, the psychiatric, the severity of functional dependence, and we can kind of move based on how many of the criteria you satisfy. Here they want you to have 2 out of the 5 categories. You can go into probable CTE or possible CTE or TES or definite TES.
And that's where I'm looking at the screen up here that Robert Cantu built. And this is where we went with you, Paul, on your diagnosis with Bruce Parkman. Mm-hmm. You meet all the criteria.
A Green Beret diagnosed me. So.
Yeah, perfect. Yeah,
but he's actually he's wide open about it. He says he's in his 50s or late 40s or something like that.
Right.
Anyway, and he's
Can
very
you put
open,
that back up in
saying that there's a high probability that he's going to be dealing with or already is. But.
And so. And we make fun of Paul. I make fun of Paul for this all the time. Is that meets the criteria? Yes, he meets cognitive impairment. Yes. Determined level of exposure contact. More than 11 years.
2020 of organized football.
But here's the big thing. Here is meets the following delayed motor signs, psychiatric features, neurobehavioral dysregulation, mild dementia or worse. You've never formally been diagnosed, so you go to the no.
Well, I go to the no, but people have asked me in the past, are you depressed? What's going on? And I always felt, I had a son with myotubular myopathy, very, very rare disorder, muscle disorder, and he passed 40 days shy of his 16th birthday. And I'm like, yeah, of course I'm depressed. I lost a son, but things have gone on for years and years where I definitely have a deficit of, A, B, C, D, I was listening to one of your peer neurologists on a YouTube TED Talk.
Okay.
And she says, well, if you find yourself, it was the talk about getting into your 50s. And she says, if you find yourself losing your keys, your car keys, and you look around and all of a sudden 5 minutes later, you find them in your coat pocket, that might be just aging a little bit. But if you lose your keys and you look for 5 minutes and you finally find them in the refrigerator, that could be an issue. So,
yeah. Or if you don't even recall losing your keys.
Or going 5 times to get a bottle of water out of the refrigerator. Yeah. Mm-hmm. Putting the coffee in the refrigerator instead of in the cupboard.
Have you?
Oh, yeah.
And a lot of these symptoms are also very deep, personal, and so the doctor also has to make a connection with the patient and really understand how things have evolved or changed over the course of their life.
And so you look at me, then you go down to, I meet the criteria of 11 years, means delayed onset motor skills. You're my doctor. Do I got delayed onset motor skills?
Well, there is the imbalance, which would include that as well.
Right. Psychiatric features, neurobehavioral dysregulation, and mild dementia. Yeah.
Yeah.
Mm-hmm. Well, one of the things, we're talking about billable TES, and how do we? So yes, Corey has been on me to go through the process. I would venture to say, somebody like Corey bringing tests that he has validated, and he has copies of these tests from 20 years or 1999. Yeah. All the way up until your TES diagnosis, which was 2 years ago, probably a year ago.
2024, wasn't it?
Yeah. Mm-hmm. So all of that makes a difference, because you said a very important word, baseline, and would that? I'm hanging myself, Corey. So and once
you can take that off now, Amina.
Once the professional football, the concussion lawsuit settlement was going, they at that time they started giving us the opportunity to get a baseline. Now, my baseline came, 15 years after I retired.
Yeah.
So that's not really a baseline.
The only thing that would be helpful is that you now have a new baseline in case things were to progress further.
Mm-hmm. That's so I'm, again, in my simple thinking, I'm thinking, what, are they getting, we're talking about changes to make the game safer, well, I'm thinking about baselines for kids that are getting in. First of all, I strongly advocate flag football until you're 14 years old at least, and I'm almost starting to kind of push it up, but which is you can get
what does Brett Favre say?
He says 17.
Yeah, I would be kind of more inclined to side with Brett Favre, and that maybe we should do no contact or less contact until like the college level, and that at least like delays. Because also young kids, their neurons are not as myelinated as adults are, so they're more susceptible to injury. And once you lose neurons, those neurons don't often come back. We're able to fix our symptoms by that plasticity and developing new connections, but you're basically throwing in kids who are more vulnerable.
Mm-hmm. Yeah.
Well, that and your myelin sheath takes how long?
The prefrontal cortex, the myelin sheath around the axons are not completely developed. Sometimes into your 20s, but that's the case. But I'm also getting to the point where, Ann McKee has a beautiful presentation.
Are you going to say it? Culpable?
Yeah.
Are you going to do it?
Ann McKee she has a lot of youth. We're talking teens that have taken their lives in her presentations. Mm-hmm. And she's got to the point where, hey, this is causing young people mental anguish to the point of suicide ideation or carrying out. Mm-hmm. And it's a tough, it's a tough topic, and it's a very touchy topic, but I'm almost to the point where if we can educate these parents of the damage that their child is causing in their brains, if we can educate them, it's almost like I would like to say the parents would be culpable for putting the make sure before you put a chin strap on your kid. Well, no. I think the parents would be culpable for their child's mental health as a young adult and into their adulthood if they allow them to put the chin strap on at 7 years old.
Yeah. And it reminds me too of, so I watched that documentary about Tyler Sash with Brett Favre. And, you know, there was one line in there about like, he took like a severe hit in Pee Wee and was like days stumbling around. And his dad was the coach and ended up like kind of pushing him back into the game. And I think those hits are probably the ones that really make a big impact later in life. And if we can delay that as much as possible, I think that will be really helpful. So we're trying to make the game safer, but that doesn't always mean softer. I think if we impose some of these smarter rules and strategies, and also educate families about the dangers that they're taking on. You know, I also don't want to necessarily strike fear into families saying that, you know, if they play, they're going to get CTE.
Right.
But I think some of these little things, if we can make the changes, I think that could make the game a lot safer and still allow the sport to happen.
One statistic, what
I think, and I've talked about this quite a bit, is I think rodeo, hockey, soccer, football, any contact sport from junior high up, because Pee Wee football is by parents, so you can't set that up. But your first organized junior rodeo, whatever, before you compete, you have to go do a 1-day talk on head impacts and repeated head impacts. So you are aware of the things that you're about ready to put your son into. And it's like Bruce Parkman said, you know, it's horrible because the dads, we're men, go hit them.
Yeah.
But you get Mama Bear involved.
This episode of the Head Rush Podcast is brought to you by our personal doctor and team of doctors, Dr. Mizell DeMayo, and she's with the Paradise Behavioral Health, and we are in the
Brainwell program, which is also part of the Millennium Health Center. Dr. Mark Gordon, you've seen him on Joe Rogan and even on our show, the Head Rush Podcast. And the hormones. And Mizell is awesome. We love her.
She's our doctor of psychiatry. She works the Mark Gordon program with the hormones, and she adds her twist of genetics, and it basically is melding two wonderful mediums together, and we're getting great help from Dr. Mizell DeMayo.
So please check out her website at paradisebehavioral.com. Look up the Brainwell program. Get involved.
She's sponsoring us. They're sponsoring us for the next year, so we are excited to have them on board and shout the good news to everybody that is watching these broadcasts. So,
is she helping you, Paul?
Absolutely.
She's helping me. So go check her out. ParadiseBehavioralHealth.com.
One statistic that Bruce Parkman says over and over again, and I never experienced this in the professional league that I played in, but it was they only bang their heads once a week, one practice a week. We banged heads at least 3 to 5 days a week. And in you know, the statistic of if you go from 5 or 4 to 1 or 5 to 1, you're effectively taking almost 80% of those repeated head impacts out of the game, out of the factor.
Yeah, and some of those changes can make a big difference, you know, and some of the little changes already that have been done, like late hits on the quarterback, hitting a defenseless player, targeting to like the head or neck area. And, it doesn't take away the risk, but at least it minimizes it a lot. And I do think it's important that the culture also needs to change a little bit. You're taught to push through the pain, fight through it. You can't let your team down. And so if you get hit, there's a lot of pressure for if you're feeling dazed, there's a lot of pressure for a 15, 16-year-old kid to go back in and, tough it out. And
don't be a puss.
Yeah. And they could probably do it just fine. But it's it's that accumulation of hits over time that really gets them.
Well, we did the math, and we figured I'm probably roughly 10,000 RHIs in my lifetime.
Sure.
You're 14 or 15,000.
I when I was going through the trying to find the biomarkers at Boston University 8 or 10 years ago, one of the questions was, how many times have you had a concussion? I said, I don't know. I've been knocked out 3 or 4 times, lost consciousness. And then they said, how many times have you seen the color purple, stars? And they listed like 15 things off. And I'm like, I don't know, thousands? And yeah, I mean, and I always thought it was crazy to say 10,000 hits, but yeah, I definitely, if that's a statistic of 1,000 to 1,500 hits per year per season is legitimate, then yeah. 20,
and how many seasons did you play?
Well, 11 professionally and another 9 organized football.
20. So you're over 20,000 hits.
How many? Just like Andrew Marr, have you ever seen the movie Quiet Explosions?
Oh no, but that's actually on my list. Great movie, and it features a Green Beret blast explosive specialist, and he says when they're getting into that topic of how many hits, how many licks of a lollipop do you get to the Tootsie Roll, right? It's everybody's different. Yeah.
And what is it? BDNF? Is it a genetic factor? Is it who knows what it?
Well,
what
and
it
I
is.
think genetics come involved with it. I mean,
Yeah.
It has to.
I think your childhood comes involved. Genetics come involved. I think it's trauma as a child.
Yeah.
I mean, it was funny because I don't know if you know this, and I just found it out recently. I had my first concussion at 6 months old.
Oh, wow. So what happened then?
They stopped at the top of the Altamont, my mom's husband at the time, and he had to get out to pee, so they stopped at the top of the Altamont in California between Livermore and Tracy, and they went to get me out of the seat. Well, you're talking 6 months, so December of '69, and they banged my head on the door jamb, the steel door jamb of the pickup.
That's what happened?
Yeah, that was the very first head impact I had.
Yeah.
And I'm sitting there going, I'm sure that didn't affect nothing. They said I was wild for a little bit, but I'm sure it didn't cause brain damage. I think me being raised in a small town country atmosphere where we play sports, we fight, we drink beer, it was buck up, shut up, and get up. I remember playing football and getting my bell rung in high school, and the coach looking at me saying, "What's wrong with you? Get in."
Yeah.
Don't be a puss.
In those coaches' defense and parents' defense, before this became an issue,
They didn't know.
They didn't know, and I never really. It just dawned. I mean, it just occurred to me that why would I get out of the game if I had to? I saw stars. I'm going to shake it off, and I'm going to be fine after 20 seconds in the
they'll
huddle.
go away after a few minutes, and you'll be fine.
Well, and it's like rodeo. I remember getting knocked out, and we were driving to the next show. we were supposed to be at another rodeo in California, and I guess I thought I was in Texas, and I was ready to beat the heck out of the guys I was with what the hell are we doing in Texas? We're supposed to ride in California tomorrow. What are we doing? And pissed.
It's only 30 hours back
I know.
to California.
But it's just crazy. And I remember getting on my next horse, knowing that I'm not right in the head. I was fuzzy. But let's see, do I doctor out? Well, then I got to play that game. Do I on-site doctor out? Well, I still got to pay my entry fees and my dues and all of that. Or do I get on, pay my entry fees? Cheapest way out of it is to go on. And maybe you get lucky enough and get a score, you know. So, I mean, I jumped back on and went.
There's a lot of pressure. Yeah.
Right.
I remember
And
also,
then Cowboys looking at you and say, come on, don't be a...
Yeah.
I remember, and I'll say the town. It was a Hempstead Rodeo in Tracy, California.
Is that Hempstead, New York? No, you said California.
No,
Okay.
Hempstead Rodeo Company.
Okay.
In Tracy, California. I went out on this horse, and it wasn't a real rodeo arena. They just ripped the field and put panels up around it. So big old mud clods. And I had to ride a pro show. This was an open local. But I had to ride a pro show, and I was like, no, I ain't going to do this, man. This is stupid. And my buddy at the time, my traveling partner, is like, don't be a wimp. Come on, let's go. Let's do this. Cowboy up. And I went, oh, okay. So I got on, and I went out, and at about the third jump, he tripped on one of the mud clods. And I lawn darted, I mean, straight on my head, my neck rolled back, my back was on top of my head, my feet were in my face, total scorpion. Yeah. And I'm just laying there going, God. And he walks out to the arena, and the EMTs are, don't move your head. And he walks up and he says, come on, get up, quit, let's go. We got to, and I was like, yeah, get me up, Doug. I don't want to listen. And we got up and just walked out.
Yeah.
You were going to mention the pressure, or what would?
Yeah, well, like
the peer pressure right there.
It's NHL playoff time, so I've been watching a lot of the games.
Go Stars!
Yeah, go Stars! So in the last series against the Avalanche, there's the game 6. I remember. Leon Bichsel, he was going around the net and kind of slid and hit the boards, and he seemed pretty I don't exactly know what happened, but he seemed fairly motionless on the ice for at least couple seconds, and then he went into the tunnel, and then towards the end of the game he was back on the bench. I can't remember if he actually played, but he definitely played in the next series. Right. And so stuff like that, he may we really don't know. He may have, passed all the necessary protocols, but we also know that sometimes concussions can have a delayed onset where you might not start to get symptoms for a day, couple days, even up to 7 days after the injury. And so I think those kind of hits, we may have to be a little bit more cautious on when we put players back in.
And explain that again. One of our questions we were going to ask you, what's the difference of a concussion and post-concussion syndrome? Did you just explain that, or is that different?
Yeah, I kind of use them interchangeably. So I refer to concussion as the actual trauma, and then the post-concussive syndrome is kind of the symptoms you develop because of that trauma.
Mm-hmm.
So what's the difference between a concussion and a TBI?
Essentially, they're also the same. So concussion, typically, we use the term concussion to describe mild traumatic brain injury. But that mild part of that traumatic brain injury doesn't necessarily refer to the symptoms. It refers to the radiographic findings, which means that the MRI or CAT scan doesn't show any evidence of bleeding, axonal injury, subarachnoid hemorrhage. So you refer to it as a mild traumatic brain injury.
So my accident in November that I was amnesiac for 3 days, I believe. Out on my feet, bought a car, didn't know it. You know, I did a lot and didn't know it. But I didn't show any symptoms because I was amnesiac until that Monday or Sunday or whatever day it was. I can't remember. But that was a concussion.
Yeah.
Now, I've always been told, and I've counted, I think I must have had 15, 20 concussions in my life easy. You know, every time you get bucked off and hit your head, it's probably some sort of concussion.
Yeah.
Or getting bucked off your backyard horse and hitting your head. That's I can relate it now to probably being a mild concussion, moderate concussion, yada, yada, yada. I've always heard that, like a heat stroke, once you have it once, it's easier to get again. And I had a neurologist in Oregon tell me once you've had several concussions, it's easier to get another one, that your brain's already. And then we were talking with Jim Bob Custer, and didn't he bring up the dopamine levels and the excitement? And that changes our personality because our excitement of riding a bucking horse or hitting players, our dopamine levels spike, which raises our...
He had the word for it. It raises the level of, I guess, excitement.
Excitement or
endorphins.
Yeah, endorphins.
Yeah.
And once you quit hitting that and we retire rodeo or football, that doesn't lower. So that changes our psyche because we're still chasing that, but we can't do it no more.
Yeah, it's like, so there's a couple of things there, I guess. Yeah, we do sometimes see that someone will have a single concussion and it'll take them maybe a day or two to recover. And then the next concussion is a month. And then the next concussion is 3 months to recover. And so there's no specific number that tells us it's time to retire. But when we start to see that progression, that also raises concern. And then the patients themselves, it can't really be reliable after an acute head impact. And that's where kind of those biomarkers come into play to help support that, you know, they're not back to normal yet. Even though they appear fine, their brain is not fine. You know, it's not necessarily like a scraped knee. The brain takes a much longer time to recover.
We're coming down to the end of our time together.
I want to ask one more question before you ask our end.
Go.
Is we got David Cano coming on, who was the director of the movie you just watched, American Concussed.
The American
Dream. Great movie.
Yeah. I thought they did
an excellent job. If you got time, do you want to sit in if he's okay with it? Or do you got to go? I mean, if you got time, we can set up another mic and you can sit in with us.
I'd be happy to sit in.
And that way we got a neurologist, we got a director, we got a football player, we got me.
That would be awesome. Yeah.
I think that would be cool. But on my MRIs and everything, if I remember right and what I tell people, maybe I'm wrong and you can correct it. He's my neurologist, correct?
Yes. Yeah.
You see me every 3 months.
Yes.
On the 14th, you're giving me 38 shots in my head and neck. Botox for my headaches.
And that works.
Yeah.
I've heard.
I believe it does. I think I have a problem. I did my Emgality shot this morning.
Oh, good. Okay.
I believe it does work. I think the problem with me is when they're both coming to an end. When my Emgality at 45 days.
Yeah, the Emgality is usually every month and the Botox every 3 months. So sometimes when those are wearing off at the same time, then you start to see a big surge in headaches. But we really like the Botox because it stays local. And so it's not like another medicine you're putting in your system where there's concerns about interactions, drowsiness, cognitive issues. And
I got, if I remember right, frontal lobe atrophy. And we were talking with Ryan Gray. I invited Ryan Gray, who's an 8-time NFR bareback rider, to come on because he goes to UNLV for that fight or flight study every year. And he's been going for how many? 5 years?
5 years, yeah.
5 years. And I invited him to come on and talk. And we were talking about it. And I got, spots on the white matter of my brain?
Yeah, so
that are getting bigger, atrophy. And then do I got back damage or is it all frontal cortex?
most of the time we see most of that damage kind of in the front or temporal lobes because they sit right behind a bony structure and are more prone to trauma. And so, yeah, these little white matter spots are essentially scars that we see on the brain, small enough to where they're not going to cause symptoms, but we get more concerned as we start to see more of them or bigger, and then you start to see more brain atrophy along with that.
And my spots got bigger from the last couple, correct?
Yeah, and that's something we can see, that progression of white matter changes.
In October, I go down and see Tanner again. On the 15th, I do a neurological exam, blood work, and brain MRI.
The whole thing.
The whole gamut. And then I go back and see him again on the 20th to get the results of everything. And it's completely awesome having Kaytser and Tanner. One, you guys use the same, website or whatever it is, UT Southwestern, UT Austin. You go,
yeah.
You're
the same system.
You're right, the same system. So he gets to see all the notes that Tanner puts in, and Tanner gets to see all the notes that he has done for the whole year. He's my local neurologist that sees me every 3 months. Tanner sees me once a year. And I think having them both together just...
You might need them to see you step it up a little bit. The whole.
I think he's getting tired of seeing me because it seems like every time I talk to him, there's a new problem. Matter of fact, you put me back on Adderall, and I think it's helping. Put me back on Lunesta to help me sleep every night. And I think we need to maybe up that galantamine up a little bit, that my brain is slowing down.
The patient is acting like the doctor now.
Yeah.
No, come the 14th, we'll talk about it all.
We'll go in detail.
Right, but I just wanted, since I had him here, that I got my neurologist kind of setting down a foundation.
You're getting an extra appointment free. So
well, no, it's not that. It's, so the people that are watching this hear that I'm not BSing about all of my 25 years of symptoms and everything, that I got my doctor right here telling me, and I think you ought to go see him while you're in Texas next month.
Yeah, the next month. What are you talking about? October or
no? June 13th.
Oh, okay. Well,
you can see him,
we'll see if
and you can get started on. Well, you're going to the Cleveland Clinic in July.
Yeah.
Okay. Yeah.
Well, so we are just about out of time. We love ending this. In fact, so Corey, you're talking about your doctor's appointments and seeing the neurologist and Dr. Kaytser, another neurologist. The key is we want to bring hope and awareness to repeated head impacts.
Awareness. Right.
And then we want to bring hope. And it would be pretty cool to, see when you get those examinations, come back and we're going to share and see if you're doing good, if you stabilized, if you're doing a little better, whatever, And obviously I've got to step it up and start getting updated with my...
And so before you ask him for his last hope comment...
Yeah.
Are you one of the neurologists that want to see TES as a diagnosis to help with RHI and RBE? Or are you thinking it needs to stay in the research? I believe it needs to become a medical diagnosis so it can help out all the people with the RHIs, RBEs, and all of that.
You got to have the research to get that, right?
It's the next step in evolution from CTE, and patients want to have a diagnosis. They want a name.
It helped me. It made me come to terms of, okay, now I know what I'm dealing with.
And then we can focus on treating it.
Right.
Yeah.
Because the one thing I hated to hear, and I'll say it in front of my doctor, is yeah, you got TES. We can't treat there's no cure, but we can treat the symptoms.
Mm-hmm.
And it was like,
well,
that's BS, you know? And so that's when I talked to you and we got on Gordon, and I'm trying everything.
Right.
And what I'm hoping for is one day Ann McKee or Tanner or you or whatever great neurologist shows up and says, here's this pill.
Yeah.
And that could be part of my hesitancy with throwing out the diagnosis, because, okay, you have the diagnosis, but it doesn't necessarily change. You know, you still have these symptoms. We're going to try to treat them as effectively as possible. We have good treatments for migraine. We have good treatments for depression, impulsivity, dementia syndrome. So we just got to keep trying to do our best.
And I think
I told my therapist, back to your point, what we were talking earlier, Crystal, our therapist,
right,
is that, well, my therapist, is that it needs to get more awareness out there, because when she saw me, I knew what I was dealing with. So I told her up front. But if someone off the street came in and wanted to get consult because he needs therapy, she comes in and all of a sudden doesn't know none of the background. Here's depression, put you on an SSRI. Here's this, shove this in your face. What is the failure rate for an SSRI? In our case, 80% with the brain damage.
Well,
you kill me, but it's not your fault because you don't know.
Yeah.
So now at her office, RHI is on the intake form. Did you play sports? Did you do this?
Okay.
She changed her intake form because of me educating her. And I think that's why TES, because we can educate these doctors to be able to understand our background more and ask the right question. Because if you looked at Paul, would you know he was an NFL player right now? No.
Just on his size.
Right. Welcome to the Head Rush Podcast, brought to you by the Patrick Risha CTE Awareness Foundation. Karen Siegel, thank you so much. Paul?
So go to stopcte.org, learn about their foundation, and they are sponsoring us for the next year. We are thrilled to have them team up with them and bring awareness to this disease.
So please go to their Facebook page, go to their website, check them out. Karen is very, very, very willing to work with you. Contact her, and if you do know her, thank her for us, or just go on their Facebook page and say thank you for sponsoring the Head Rush Podcast. Or a basketball player.
There was a day, Corey.
Oh yeah, we got pictures of it.
Long ago.
So ask your hope question. We got to go, but I just wanted to bring that to that this is what we're all talking about on awareness.
Yeah, you're very fortunate that you have a doctor of neurology that actually will look at possibilities and will look at different therapies and so on and so forth. So, and okay, we got to, things have to be studied beyond that point of any doubt, and that's where we're trying to get to. You know, the studies, the clinical trials, the things that.
Well, I think to get diagnosed, you got to have a hell of a foundation to get it.
Well, and that's why,
you know, I got 25 years of medical records.
You had a stack going on. Yeah.
You know, it wasn't, I just didn't come in and say, yeah, I played football in high school and now I got depression, suicide, ideology, I got executive function. Diagnose me. No, I mean, I have.
You had 5 terabytes of information for Dr. Tanner. So.
I don't know what a terabyte is. So
it's a how many no, not megabytes.
1,000 gigabytes.
It's 1,000 gigabytes.
What's a gigabyte?
1,000 megabytes.
Okay. You guys,
it's computer storage. And the only reason I know is because I have to freaking increase my stuff all the time, and they make me. They got us. They got us. Yeah. They make the programs bigger, so you have to buy more storage, right? Anyway, all right. So we got
Paul.
Well, this I want to intertwine. So we were talking before we got on air, and we talked about, how the community as a whole is responding to a lot of these issues we've talked about. What changes are being made, and with that, our final question is always focused on giving people hope. And we want to give hope regarding their brain health and wellness. How do you give hope to a patient dealing with these issues?
Yeah, and it's a lot of information. We tend to hyperbolize a lot too, and that's mostly to
What's that mean?
Basically exaggerate to increase like awareness.
I needed to know that too, but
Yeah.
I've heard that word a lot. So.
It's important for families, coaches, anyone around a player to be able to recognize some of the signs and symptoms early, and and also for the players to be more comfortable with sitting out when they're not feeling good, and allowing that brain to heal. And although we may not have a confirmed diagnosis yet for TES or CTE in the living, I think it's important for families to recognize some of the subtle changes that can be seen, like gradually worsening depression, addiction, forgetfulness, and seeking out help and starting some of those treatments and improving quality of life. So there's still a lot of hope, a lot we can do. And as the science evolves, as it changes, we'll change with it and, offer more support.
And you're at UT Southwestern in Fort Worth, Texas.
Yes.
And you are accepting new patients?
Yes, accepting new patients. My focus tends to be headache and traumatic brain injury, but I see a lot of neurology as well.
And, I got to say, when I got in my wreck in 2022 and I had to go through a different program and see a different neurologist, I'll flat out say that doctor didn't know
Shinola. Something from Shinola.
Shinola.
Yeah.
When I went and saw you immediately said, let's put you through concussion therapy. He sent me to Fort Worth rehab.
Yeah.
And I went through cognitive, vestibular,
vision. I think the problem is there's all these symptoms. If you only treat one of the symptoms, you still run into that risk of having that snowball effect with migraines leading to sleep issues, to depression, to cognitive. So it really has to be this multidisciplinary approach. And there's not a lot of people that see traumatic brain injury, and even fewer neurologists that see traumatic brain injury. And
I mean, that was a godsend for me because I went 2 days a week and, getting the TES clinical diagnosis gave me a reason to fight. Okay, now I got something to deal with. Now you're giving me ideas. Hey, let's put you through this concussion protocol. And I went through that and it helped. They got me glasses because I was having vision problems. Double vision. Now I got prisms, and they made me touch lights and walk and do all of that, and it helped. And I'm still going to vestibular therapy weekly still today to try to help out. And so, I mean, when you get to the right neurologist, and I'll flat recommend Kaytser to anybody that's got these problems. If you think you have RHI, concussion, or anything, you need to find a neurologist that knows what they're doing, because a lot of these dang doctors don't. And I dealt with one for a year. Is that how long I saw him before you?
That sounds about right, yeah.
And he was a moron. Dr. Maroon, moron. If you don't know, don't guess. You got to get to the right neurologist, and you have done research. You've met Ann McKee. You specialize in all of this.
That's part of the criteria, meeting Ann McKee.
That's part of the criteria. But I mean, you have followed this, and you knew about the research that just came out today.
Yeah.
That me and you were talking about when you walked in. I said, yeah, there's a new research. And you knew about it the day it happened. That's the type of doctors we need. And that's why I like having you. I love having you come on our podcast and talk about this and understand. And you're open to everything. And so I suggest people go see you. Hopefully now you get flooded and you can't take new patients. Because,
well, thank you. Yeah.
But make sure you knock me in the front door.
Of course. Yeah.
Yeah, you give him your own special key, right?
That's right.
This is why we do the Head Rush podcast. We bring in guests like Dr. Victor Kaytser, and you've heard from somebody who has been dealing, Gory has been dealing with neurological issues since 1999.
How long have you been dealing with it?
Oh, a long time. No, you're going to make me tell my little story. No, I definitely had a change in my mid 40s, absolutely flatline change. How long have I been dealing with that before? Years. And this is another, which came first. I have an addictive personality, and I drank too much. I drank my share of beer, and fortunately, I have not done that for the last 7.5 years, and it's a miracle. It happened for me, and it can happen for all other people dealing with addiction, but. We bring guests like Dr. Kaytser on to help us raise hope, raise awareness, and give us hope that there are things that you can do for traumatic brain injury. There are ways that you can, deal with headaches and migraines and so on and so forth. But please, tell your friends to tune in to the Head Rush podcast, share. What do you say? These kids say nowadays,
like and
share,
subscribe.
and like and subscribe.
Go to our YouTube channel and subscribe. We got over 235,000, 240,000 views on Facebook. We're over 1,000 followers, 600 likes.
And this is just in a short amount of time, three months.
Right.
Yeah.
But if you go to our YouTube channels, our Apple channels, our Instagrams, our everything, just like, share, subscribe, and help get this word out for hope and awareness, because I believe we're the only ones that are suffering that are actually talking about it.
It's whoever is out there we're dealing with the repercussions of repeated head impacts, period.
Say that 3 times faster.
No, thank you. I barely said it the first time. Right. and we, fortunately, we're able to talk about it somewhat intelligently. But that's why we bring guests in like Dr. Kaytser, right? That can really talk the talk. So,
and it's important to get the patient's perspective. I always say it's not me telling you what medicine you need to take or what treatment to do. It's a team effort, and so more awareness, more collaboration. That's what's going to get people better.
That's great.
That's
Good.
awesome.
We'll end it on that.
Have a good one. Thank you. Stay alert.
And stay alive.
This podcast is for general information only and does not constitute the practice of medicine. The use of this information and the materials linked to this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard and delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.